Thank you, ma'am. At the outset, I must thank Dr. Sharda Jain and team for making me a part of the NEEV mission for Viksit Bharat. The objective of this presentation is to understand clinical signs of impending uterine rupture, discuss real-life case scenarios, highlight timely diagnosis and management, and prevent maternal and fetal morbidity and mortality. Uterine rupture is complete disruption of all the uterine layers, including serosa, and is usually associated with extrusion of fetus into the peritoneal cavity. In incomplete rupture, serosa is intact. In scar dehiscence, only previous scar is involved, no fresh muscle fibers are torn, and serosa is intact, while in scar rupture, fresh fibers and serosa are torn. Impending rupture is the warning phase before actual tear, which usually occurs in scarred uterus during labor. Etiology is previous cesarean section in 0.5 to 2%, classical cesarean section or any other uterine surgery, obstructed labor, excessive uterine stimulation, malpresentation or CPD, grand multiparity, external trauma, and placenta accreta spectrum. Pathophysiology is overdistension, thinning of lower uterine segment, compromised blood supply, ischemia, incoordinate uterine contractions, and imminent rupture if unrevealed. Warning signs are history of prolonged labor, maternal restlessness, anxiety, patient is thirsty, exhausted, febrile, pale, tongue is dry, constant lower abdominal pain also in between the contractions, tender, distended uterus, Bandel's ring is available and palpable, and there is hot, dry vagina, vaginal bleeding may also be there, hematuria is usually present, and there is fetal distress, which is the first sign to come up. So this is the first case, Gravida 2, Para 1 with previous cesarean section in active labor on oxytocin augmentation, severe lower abdominal pain, fetal heart dips to 100 beats per minute. Patient counseling, red flag signs and immediate actions needed are what is to be thought about. So patient counseling, if the patient is for VBAC, you must counsel that VBAC is associated with an approximately 1 in 200 risk of uterine rupture. The success rate of planned VBAC is 72 to 75%. Women with 1 or more previous VBAC have a success rate of 85 to 90%. There is 2 to 3-fold increased risk of rupture and around 1.5-fold increased risk of cesarean delivery in induced or augmented labor as compared with spontaneous VBAC. So always leave these patients for a spontaneous VBAC. Induction of labor using mechanical methods, that is amniotomy or Foley's catheter, is associated with a lower risk of scar rupture compared with using drugs like oxytocin or prostaglandins. Now, how do we manage this situation? Diagnosis of impending rupture in previous cesarean is possible with continuous monitoring. Look for scar tenderness, stop oxytocin, resuscitate the mother. Continuous fetal monitoring is to be continued and prepare the patient for immediate cesarean section. Features suggestive of uterine rupture, abnormal CTG are seen in 66 to 76% of the subjects, severe abdominal pain, especially if persisting between contractions, acute onset scar tenderness, abnormal vaginal bleeding, hematuria, cessation of previously efficient uterine activity, maternal tachycardia, hypotension, fainting or shock, loss of station of the presenting part, and change in abdominal contour and inability to pick up the fetal heart rate at the old transducer site. Most uterine rupture, that is more than 90%, occur during labor, the peak incidence being at 4 to 5 centimeters of dilatation, with around 18% occurring in the second stage of labor and 8% being identified post-delivery. Now, the case 2 is a primigravida in obstructed labor, prolonged second stage, tender uterus, Bandel's ring is present and hematuria is present. Diagnosis impending rupture due to obstruction. The correct use of partogram and close monitoring can help in early diagnosis. Patient is exhausted, thirsty, pale, tachycardia, hypotension is there. Lower segment is stretched out, bladder is pulled up, uterus tender, Bandel's ring present, FHS may be absent. Hematuria, edematous vulva, large caput, conical descent, and grade 3 molding is usually present. Immediate management is to stop uterotonics, hydrate, broad spectrum antibiotics, catheterize, emergency cesarean section by senior obstetrician with blood and blood products arranged. Keep ready for difficult delivery by Patwardhan or push technique. Angle extension may occur, bladder injury may occur, PPH may occur, so keep readiness for it. Keep ready for birth injuries, intracranial hemorrhage, asphyxia, and fetal distress. Prolonged catheterization may be required to prevent fistula in such cases. Another scenario is Gravida 4, Para 3, Live 3 at 38 weeks, grand multipara in spontaneous labor, sudden cessation of contractions, and fetal heart is absent. In this situation, the person must have missed the signs of impending rupture. Data is inconsistent regarding grand multiparity, that is, a woman who has delivered more than 6 times is not at risk of uterine rupture in normal labor. However, labor augmentation and induction during trial of labor after cesarean section in grand multipara has a similar uterine rupture risk as in multiparous parturients. Monitoring during labor is to be done with continuous maternal vitals, fetal heart monitoring, partogram observation, regular vaginal examination, assess uterine tone and contractions, and keep a caution with the oxytocics. Management, CBC blood group cross-match is mandatory in gland multipara. Be careful with the use of prostaglandins and syntocinon. Careful partogram and CTG monitoring has to be done. Detect early, recognize clinical signs, act promptly, resuscitate and operate. And also don't forget to do ligation in these patients. Postoperatively, blood, counseling, antibiotics and catheterization is very important. Avoid unnecessary induction and augmentation in grand multipara. Adequate pelvimetry has to be assessed. One-to-one intrapartum monitoring has to be done. VBAC only in equipped centers, and patient education is very important. This is for all the case scenarios for rupture uterus. The take-home message is, impending rupture is a preventable emergency. Early recognition saves 2 lives. A vigilant obstetrician is the best monitor in the labor. Thank you very much.